Hi, everyone. Hope you're all having a good afternoon and having a good, first week of this new year. So today we're going to talk about a journal article that I found titled Spironolactone as a Potential New Pharmacotherapy for Alcohol Use Disorder. Okay, so here are the objectives for today. Briefly, I'll describe the clinical relevance of the studies leading up to this journal article in question, talk about the basics of spironolactone as a medication, and then we'll kind of transition to the article and the research that they did. So here on this first slide are the DSM criteria for alcohol use disorder. I won't go into detail on this here either. We're all very familiar with this, but alcohol use disorder essentially is a problematic pattern of alcohol use leading to clinically significant impairment or distress in one's life. Typically, patients engage in compulsive drinking, have loss over their control of their consumption, which leads to loss of control and disruption in their own lives. I think we all can think of one patient or actually several patients that are suffering from alcohol use disorder. And based on what we see in the clinical setting and what we know about it in the research sphere as well, I think it's safe to say that this should be classified as a brain disorder. So epidemiology, in 2019, alcohol use disorder was found to be in 14.5 million people in the United States, ages 12 or older. Based on this number, there were more males affected than females, and about 86% of those over 18 have consumed alcohol at some point in their life. I don't find this statistic terribly surprising given, the prevalence and availability here and kind of the popularity in younger individuals to drink alcohol. But it is, responsible for a large burden on public health. It's responsible for about 2.9 million deaths globally, specifically in the years, 2006 to 2010. About 1 in 10 patients from the ages 20 to 64, their deaths were attributable to, excessive alcohol consumption. And, associated with that public health burden is, the economic burden as well, costing this country almost 250 billion each year. And when you think about that number, if you can think about just hospitalizations alone, alcohol use disorder affects compliance with treatment, and it's overall associated with an increased rate of hospitalization. So it's no surprise that alcohol use disorder is associated with a variety of medical comorbidities, liver disease, to, name a large one, but, transitioning to its role in psychiatry in general, alcohol use disorder and overall, heavy alcohol consumption is associated with mood disorders and personality disorders. Specifically, alcohol use disorder has an increased risk, or patients with alcohol use disorder are 2 times higher afflicted for patients with psychiatric comorbidities. About 40% of patients seeking treatment for alcohol use disorder report at least one previous suicide attempt in their lifetime. And surprisingly, about almost 30% of those who completed suicide were found to have alcohol in their system. And just given these numbers alone, what we know about the disease itself, I think it's, imperative that we find a treatment that works for patients. I know that it's not as easy as, one pharmacologic treatment or one therapeutic intervention. It has a lot to do about meeting the patient where they're at. But I think that, these numbers are shocking, and it's overall a devastating problem for our patients. Listed here are the current FDA-approved treatments for alcohol use disorder: disulfiram, naltrexone, acamprosate, and Vivitrol, the intramuscular version of naltrexone. Basically, to treat alcohol use disorder, it requires early intervention if the patient is willing, but it's really multifaceted. It's not as simple as that. And listed here are some medications for off-label treatment as well, used a lot in, our SUDS rotation that we do at the VA hospital here: baclofen, gabapentin, pregabalin, and topiramate. And you'll notice that some of the medications here, most notably gabapentin, offer an anxiolytic benefit, and that will be discussed later in the next few slides, but that's important to note for this research that we'll be talking about today. And it's also important to note that of the medications listed here on this slide, even though we have 4 medications that have FDA approval for treatment, less than 9% of patients are actually treated with these medications, either short-term or long-term. So the article reviewed, this is kind of the information of the authors, but it was published very recently, last September, in Nature, which is a fairly reputable source, I would say. And then the authors did not declare any conflicts of interest. And then there's other information if you want to read over that. But then before talking about the article itself, I think we just briefly should review spironolactone as a medication, since it's not commonly used in our wheelhouse of psychiatry. But the basic mechanism of action, it's a mineralocorticoid receptor antagonist in the distal renal tubules. It counteracts the hormone aldosterone to increase sodium chloride and water excretion, and it's otherwise known as a potassium-sparing diuretic in the medical sphere. And for those of you who are visual learners, this is another depiction of the mechanism of action. You can see here, okay, hopefully you all can see my cursor, but this right here is the mineralocorticoid receptor. And here's spironolactone blocking aldosterone. So in response to decreased blood pressure or blood volume, aldosterone right here is secreted from the adrenal gland, binds here to the mineralocorticoid receptor, which facilitates water and sodium reabsorption. And then obviously spironolactone will do the opposite of that. Listed here are the current FDA indications for use of spironolactone to treat a variety of disorders such as hypertension, heart failure, edema, and ascites due to liver cirrhosis. And then off-label, this medication can also be used to treat acne, hirsutism in females, and even in special cases can be used to treat aggression. Now, preliminary studies prior to the article that we'll be talking about today have demonstrated that aldosterone and mineralocorticoid receptors have played a role in alcohol-seeking behaviors and consumption, but the role between the two hasn't been, clearly defined. And I guess it's really unexpected too that there would even be a role between this hormone and drinking. But basically, the preliminary studies demonstrated that the mineralocorticoid receptors in the kidney are actually expressed in the brain regions depicted here: the amygdala, the prefrontal cortex, and the hippocampus, all of which together regulate thoughts, emotions, behaviors, and memory. And the role of these mineralocorticoid receptors in alcohol consumption and stress is multifaceted. It's more complex than what I'm making out to be today, but it's primarily related to their location in these sites of the brain. And specifically, the preliminary studies showed that aldosterone levels positively correlated with self-reported alcohol cravings and anxiety. There was actually a study of monkeys in which they self-administered the alcohol to the monkeys, and then their blood aldosterone levels were checked, and they were actually increased from baseline in the time frame of 6 to 12 months of alcohol consumption, which is pretty interesting. And those increased levels of aldosterone were determined to be contributing to their drinking by increasing their anxiety, facilitating increased brain stress, and or even inducing neuroinflammation. The aldosterone levels also correlated to the withdrawal period that they saw in the monkeys, most notably leading to obsessive cravings for the alcohol, kind of analogous to the withdrawal period that we see in humans. And then interestingly as well, in this study, the aldosterone concentrations were significantly decreased in those monkeys who were abstinent from alcohol for a 12-week follow-up period. So essentially what I'm saying, that these preliminary studies have suggested that a higher mineralocorticoid signaling can contribute to increased alcohol consumption. So essentially, theoretically, based off of that, medications that could block this receptor could present a new treatment approach to this disease. But so far, use of spironolactone has provided inconsistent results with this. So essentially, the article in question tried to address these gaps and try to give us more knowledge on the topic. So the authors hypothesize that spironolactone will decrease alcohol consumption in rodents. So they looked at obviously a rodent model consisting of mice and rats, and then they also used a human model. And for their hypothesis for this was that the prescribed spironolactone would display a reduction in self-reported alcohol consumption. So the methods for the first part of the study, we'll kind of first talk about the rodent model and their results and their findings, and then break it up and talk about the human model. So the first portion of the rodent model, they used adult male and female mice. They were divided into 3 groups of about 15 mice each. So one group of mice received sweetened alcohol, which was consistent of about, I think 20% alcohol and 3% glucose. And this specific solution was supposed to mirror the actual type of liquid alcohol that humans consume. I guess a little bit of sweetness and heavy on the alcohol. Another group of mice received unsweetened alcohol, which just contained 20% alcohol and no glucose. And then there was a placebo group of mice that received a non-alcoholic sweet solution containing 0.3% glucose. And then they were injected with the spironolactone 30 minutes before alcohol consumption. They were injected with the doses listed here: 0 milligrams per kilogram, 25, 50, 100, and 200. These doses were based on prior studies, as well as, the body surface area of the mice that they used. And so they were injected with the spironolactone 30 minutes before alcohol consumption, and this time frame was attempted to mirror binge drinking in humans. And then the second part I found was very interesting. When they used rats, they actually were assessing alcohol consumption as it relates to alcohol dependence. So each group had 12 rats, I believe, and they looked at the average number of lever presses for alcohol between 12 alcohol dependent rats and 12 non-dependent rats for 3 days before they were given any spironolactone, and then after treatment with spironolactone at the doses described here. 0, 25, 50, and 75 milligrams per kilogram. And they were injected with this, whatever dose, 60 minutes before alcohol consumption. And the dependent rats were actually made dependent on alcohol by chronic intermittent alcohol vapor exposure. And so, of course, this part of the rodent study was supposed to mirror, humans that are dependent on alcohol. And then I guess before transitioning to the results, I should mention that they mentioned, other things such as blood alcohol concentration, food and water intake. And they also interestingly looked at motor coordination and ataxia, but I didn't describe that here. That would maybe be a good topic for another journal article for another day. So here are the results. So we'll just kind of go through each graph. They arrived at these results based on using the ANOVA statistical analysis, which for those of you who need a refresher on that, that's just a statistical method used to analyze the statistical difference, if any, between multiple groups. So here in group A, or figure A, excuse me, looking at the sweetened alcohol, you can see it's pretty clear that there was a difference between sex of the mice. The females overall consumed more of the sweetened alcohol than the male mice did. And then at doses of spironolactone of 50, 100, and 200 milligrams per kilogram, there was a significant reduction in alcohol intake between the mice. In figure B, the group that received the unsweetened alcohol, there was no significant difference between sex of the mice and no effect even on sex and dosage of spironolactone. And then at doses of 50, 100, and 200 milligrams per kilogram is where they found that spironolactone significantly reduced alcohol intake. And then the final figure here for the placebo group, they found that there was no effect on sex as well and no interaction between sex of the mouse and dosage of spironolactone. And also they did not find that any of the spironolactone doses that they tested significantly reduced intake of the non-alcoholic sweet solution. And then this figure, we have the results of the rats, those who were dependent and non-dependent. And so in figure A, focusing on the male rats, it looked like at doses of 25, 50, and 75 milligrams per kilogram is where they found that these doses reduced alcohol self-administration in actually both the dependent and non-dependent male rats. And there was no significant difference between, the spironolactone and alcohol dependence in general. And then here in figure D for the female rats, it seemed to be doses 50 and 75 milligrams per kilogram, where there was reduced alcohol self-administration, again, in both the dependent and non-dependent female rats. And likewise, there were no differences noted in the, spironolactone administration for the dependent females. So basically the main findings here, we'll just kind of break it up in mouse and rat models again. The spironolactone dose here for the mice, the dose definitely decreased the consumption of sweetened and unsweetened alcohol solutions, and it was seen in a dose-dependent fashion in both male and female mice. Although the females did consume more sweetened alcohol than males, the spironolactone seemed to be equally effective in both sexes. And then for the rat model, the spironolactone did decrease operant self-administration of the alcohol in both the alcohol-dependent and non-dependent rats. And this also showed, that they, in this part of the study with the rats, that they had motivational and somatic signs of withdrawal when they were not able to self-administer, but still, and not getting the vapor of the chronic intermittent vapor exposure. But I think it's important to note here that in the article they talked about that spironolactone did not alter any level of established tolerance in the rats. So does not appear to be a relationship between spironolactone and established alcohol tolerance. And so transitioning to what we all maybe care more about is the human study. It was a pharmacoepidemiologic approach in which it was an observational cohort study that used electronic data obtained from the VA to examine the use of spironolactone prescribed for any indication that we'll talk about in a minute. And if there was any change in self-reported alcohol consumption, the patients used had to have at least 60 days of continuous treatment with spironolactone, and to measure their self-reported alcohol consumption, they use something called the audit C, which we'll also talk about in a little bit. And the median follow-up time here was about 542 days to be exact. But the sample initially, they took about almost 31,000 spironolactone exposed patients and around 2 million unexposed patients who reported alcohol consumption in at least 2 years prior to their prescription of spironolactone. And so they had about 20,000 patients that were matched, but then in the end of the study, about 9,000, 10,000 did not have a follow-up audit C, so they had to be excluded from the analysis. So the actual, final matched cohort was about 10,726 exposed patients and about 35,000 almost unexposed patients. And this graph is straight from the article. It shows, the baseline characteristics of those patients who were exposed to spironolactone and those who were not exposed. And, the ages here, you see right here, middle-aged males, and then it divides it up here by race and ethnicity, and then by what indication the spironolactone was used to treat. And as you can see, consistent with the current indications for use of spironolactone, those who received it in this study also had a higher prevalence of hepatic disease, hypertension, and coronary artery disease and diabetes. But to match the individuals, the authors, or the researchers, I should say, use something called propensity score matching, which is a statistical technique in which there's an artificial control group that's designed to match patients, the study patients, with their specific characteristics. And so that's what they used here, just to minimize any differences between the study population. And then through this propensity score matching, I should also mention that they came up with the average doses of spironolactone that were prescribed. And then here is an example of the audit C. It stands for Alcohol Use Disorders Identification, Test, and Consumption, which is quite a mouthful. So audit C, I think, works a lot better, but this is what has been given at the VA for several years. An answer choice of A gives you 0 points, B gives you 1, C 2, D 3, and E 4. Men, if you get a score greater than or equal to 4, that kind of gives you a score of hazardous or active alcohol use disorder. And then for women, the score is greater than or equal to 3 for hazardous alcohol consumption. So let me see. Yes, these are the results here. But before I get into that, They were calculated first, the audit C score is a baseline prior to receiving spironolactone, which they had gathered from, longitudinal data from 2008. The VA, I guess, has used the audit C, like I said, for several years. And then they followed them, given the audit C test after receiving treatment with spironolactone. And then they found that the average daily doses of spironolactone that the patients got were less than 25 milligrams per day, around 25 to 49 milligrams per day, and then greater than or equal to 50 milligrams a day of treatment. And so here are the results that they found. Essentially, all of these numbers here demonstrate that the audit C scores decreased during the study in both of the treatment groups. The average audit C score decreased from about 3 points, like 3.1 to 2.2 points among exposed patients, and decreased from about 2.9 to 2.2 among those who were unexposed to spironolactone. So overall, this study on the human model demonstrates that the audit C scores decreased almost 0.2 points. If you want to round up, it was specifically about 0.17 points more among those who were exposed to spironolactone than, their unexposed counterparts. So I guess, what does this mean for us? Why are all these numbers relevant and why do we care? Some interesting points. First, the largest effect in the humans was found in the group that actually had the highest level of alcohol consumption. And then the largest difference between the patients were found to be in patients treated with at least 50 milligrams of spironolactone. And so consistent with the rodent model described earlier, the human model indicates that those who receive spironolactone for any indication reported a greater reduction in self-reported drinking than their matched controls who did not receive spironolactone. And there is also a dose-dependent response that was seen in the rat model as well. So essentially, like I said, this article provides evidence across 3 species, humans, mice, and rats, supporting the researchers' original hypothesis. I think that this article is very unique in that it uses 3 different species, and it provides, consistent results. So I think it is, promising data that we have here. But so as far as the strengths of the article itself, I think the use of the animal model, and animal, I mean rodents, eliminates variability. I think you can control the mice and the rats and control their conditions and characteristics a lot better and easier than you can with humans, even if you match them using the propensity score matching. And compared to the other preliminary studies on this topic, the researchers here used a larger human sample size that were geographically matched as well. And then the audit C scores were actually a measure of longitudinal data. Like I said, the VA has been collecting audit C scores since 2008, so you can really get good information longitudinally over a period of time. And then the humans that they used were also, the follow-up period was longer, it was about 2 years. And then in the previous studies, the researchers had only followed up with patients for about 6 months at the most. Now, to discuss the limitations, looking at the characteristics of the human cohort, they were all middle-aged males and they were all US veterans. So this population in general, I would say, is higher risk for, heavy alcohol consumption and development of alcohol use disorder. And even, the model of the audit C scores, they're self-reported scores. So that in and of itself is a subjective measure. And, you never know what setting that the patient is giving these scores and if they want to have the number improve, if they're at the doctor's office, and it just kind of is a somewhat unreliable measure, I would say. And then another limitation of the study is that there's really no known or demonstrated interaction between spironolactone and alcohol consumption. Spironolactone in and of itself is a very safe medication. It's been highly tested in a variety of conditions, like I mentioned earlier, but given, the chronic intermittent vapor exposure with the rats, or just heavy alcohol consumption in a human, there's really, we don't know what that does.
I have a little comment on that. You were saying that the middle-aged U.S. veteran males would be more susceptible. I guess we need to think about the fact that most of the people that are in the audience are not draft of an age when they were drafted. But if you take my group, everybody born before, I forgot exactly when, 75 or something like that, was draft eligible. So there are millions of, it's a different population than you think of today. People in the military, in other words, are different. They're all volunteers now. This group would have already been in my generation when everybody got drafted.
Yeah, exactly, Dr. Lippman. Thank you. That's a very good point to note.
The other thing is the doses of the spironolactone that you're citing are within the usual guidelines for the use of spironolactone in general anyway. So they're not some special group. 25 to 100 is the standard dose, pretty much.
Yes, exactly. And then kind of transitioning ahead, what we can do with this information today. I think there is, this data was impactful, but I think we still have a ways to go with kind of making something of this. I think, of course, we need randomized double blinded clinical trials to confirm efficacy and safety. So that way it could get FDA approved for this treatment indication. And that way, clinicians could actually feel, comfortable about prescribing spironolactone to treat alcohol use disorder. I think it also, we can use this information to test, alcohol consumption in a variety of settings, most notably if it could help in binge drinking in any way. And then I think, some other related experiments, you could even look at the role of hypokalemia in alcohol use disorder as it could relate to treatment with spironolactone. And then while I was, looking at this journal article and then some others, I found that there is also a role of mineralocorticoid receptors in depression. And so I think that could be another area that we could study and get some useful information from, hopefully. But then just to kind of conclude here, I wanted to kind of raise this maybe discussion question to wrap things up. I guess, we all can think about at least one patient who struggled immensely with heavy alcohol consumption. And I guess if I'll just pose this out to the audience, if you had a patient who's tried everything, they've tried multiple inpatient, outpatient programs, and their, pharmacologic treatments have still failed them, would this information presented to you today, would you, prescribe spironolactone to treat and help your patient? Why or why not? But thank you for listening to me. I hear my references. If for those of you who need them or want them, feel free to reach out. But thank you.
Wow, that was an excellent presentation. One thing, you said something about if it was approved, we could use it. We use drugs that are not approved every day. I mean, for example, gabapentin. We use gabapentin for 3,000 things. The major point I think that you made, that even though this wasn't like dynamite perfect cure, if you have it's hard to name a disease that is more common in the world than alcohol use, or certainly in this country, that it'd be hard to find anything that's worse. So if it's a small bit of help to a small group of people, that's pretty dynamite, even though the effect is small and the drug may not be approved.
Yes, I agree. I think, in psychiatry, we use medications off label for treatment of a variety of things. And so I think that if you can just show people that it could offer some benefit, that people could still maybe use it off label as well.
The other thing that you said very well, how this drug affects several sites in the brain as well as in the kidney and so forth and so on. And that's an important point for everybody to remember. Anytime you put anything in the body that you say it's a dopamine this or it's a whatever it is, it affects the whole body. I mean, just think of this drug as an example, or aspirin. What does aspirin do to the body? I take it for pain. You take it for fever. She takes it for coronary artery. He takes it for stroke. Somebody else takes it for bleeding. I don't know what, atrial fib or what have you. So this drug, who knows how many other things this drug affects? And every other drug you take affects the whole, like they say in that song, the head bone's connected to the neck bone and the foot bone. So everything is connected. Everything you put in your body affects everything.
Yes, another good point. Thank you, Dr. Lippman. I think Syed had a question, or Will had a question.
I did. Can you hear me?
Yeah.
What my question was, we know that alcohol does have, effects on fluid dynamics in the body, and that's going to be like a diuretic and some effect on vasopressin. I'm wondering how that kind of the chronic use of alcohol affects, I guess, the study, and if you found anything to kind of that indicated that might be like a confounding factor in the data.
Yeah, no, I think the human model, it was hard to know that because it was like an observational cohort, but I think that would be more apparent if it was a possible confounder, if they did something like a randomized control study, because that was definitely on my mind too, like how that would play a role and, affect things.
I had a comment too, because actually what I was thinking about is that there are confounding variables in both directions. You're talking about, other effects on fluid dynamics there, but there's also other ways that these medications affect us, and dirty receptor binding actually is sometimes a bigger part of therapeutics than we give it credit for. For instance, serotonin 2A antagonism isn't the most powerful part of a second generation antipsychotic for pimavanserin would be a more powerful antipsychotic, right? Because it's pure serotonin 2A antagonist. With regards to spironolactone, its benefit for aggression is because it also blocks testosterone.
Mm-hmm.
So, a confounding variable here could be maybe one of its benefits is actually the combination of both aldosterone and testosterone blockade. In which case you'd have to power these studies to gender differences and certainly not have just such a strong male cohort as the veterans retrospective study. By way of example, using spironolactone for aggression, especially, sexual aggression and inappropriateness, does seem like it works better than using finasteride, which is another example where the pure blockade might not work as well. So it's possible that this aldosterone blockade is part of what works for aggression as well. If spironolactone is going to be better than finasteride for sexual aggression, which appears to be the case in a very small sample size of patient reports out there.
That's a pretty interesting comment. I'm fascinated by those ideas.
I think Dr. Wong had a question, but
Hi, Sabrina. Yeah, this is Dr.
Hi.
Wong. Yeah, firstly, I want to commend you for choosing this article as in Nature Medicine. You can find the article. Yeah, so we really, for Journal Club, I think the other attendees made the comments before. We really need to find some high quality articles, not just some random article, from lower tier journals. And then so another thing is like come to my mind. I think VA really definitely have a bigger population. I think Wellbutrin, I think the VA discovered Wellbutrin can help people quit smoking. And then I think that came from VA study. I think the spironolactone thing could work. And then so and then so basically there is a ACTH, mineral corticosteroids, mineral steroids, and corticosteroids. So I guess the whole system can be the hypothalamus, pituitary, adrenal gland, are involved in the stress system, and then so I think we really need to think about what with the other treatments. But on the other hand, sort of like there's in the study it shows that only 0.17 point difference in human. So how does how does that data translate to clinical alcohol consumption? If 0.2 difference, what's the meaning of that? And then so the shortcoming in the study is they use self-reported craving and stuff. I think with big data, can we track, how much alcohol they buy if you truly want to do the study right? That kind of thing. Yeah. Another thing is sort of like, I really want everybody sort of to have to look at the bigger picture, when you present this kind of stuff. So for alcohol, I will refer everybody to Nora Volko's, research. She's the head of NIDA, National Institutes of Drug Abuse. And then so she has wrote extensive reviews, on addiction problem. And then so she talk about, sort of addiction starts with, addiction starts with, somebody need to mute their mic. Anyway, addiction starts with the pleasure pathway. And then, but when they become addiction, the problem is moved to frontal cortex. So if you talk to the patient, you check their, when they use the drug, they'll say, I don't even get high anymore, but I still have to use. So almost become some sort of obsession, compulsion kind of thing. So I think early on you show the receptor exists in prefrontal cortex, some other areas. I think those are all very important, worth exploring. All right, thank you.
Thank you.
Thank you. Are there any other questions from the audience?
Something that I noticed, and going back to what Syed mentioned on alcohol's effect with vasopressin. I mean, if you look at the non-matched cohorts, like the full cohort and the exposed cohort, it looks like the people who are already on spironolactone or exposed to spironolactone. It says that in terms of alcohol abuse disorder, the never is 65.9% compared to the unexposed group, which is 80.5%. So it looks like alcohol not only affects these fluid concentrations and makes it more susceptible to get coronary artery disease, it also makes you more likely to be put on spironolactone, which treats alcohol use disorder. So it kind of leads to a circular type thing there. That's just my comment on what I had mentioned earlier. My question for you is, when you're doing the rat studies, they use two different strains of rats for some reason in the two different studies. Do you know why they did that? Did they make any mention of that?
Good question. They didn't make any mention of it, but out of my own curiosity, I just Googled, like, there was a string of letters for the mice. I think it was like CBJ / I think 57. And I think that is just a basic type of laboratory mouse. I think that's just easy to breed. And then as far as the Worcester rat, I would assume the same thing, but I don't know. They didn't mention it though.
Yeah, so with animal study, basically they can create animal models for alcohol addiction, and then so they'll inbred the animals who consume more alcohol. So after several generations, you'll have alcohol high intakers versus other through other inbred you'll have alcohol low intakers. And then the mice, they don't like to drink alcohol. You have to add sugar in there to sweeten it to induce them. So that's why they're using the sweetened alcohol. And then so I think they use two models, one's from mice, one's from rats. Rats is called Winster. I think the mice model is probably some sort of inbred. They create some high alcohol intake like strains of mice.
Gotcha. That's interesting. Thanks.
Are there any other questions or comments from anyone?
Good job. You did a good
Thank you.
job.
Thanks.
Good selection, important issues, good comments from the audience.
Well, thank you everyone for attending this grand rounds.